Welcome to the third video in the MRCP PACES series, focusing on the cardiovascular examination. We will cover a full routine, 4 common cases: aortic stenosis, mitral regurgitation, aortic regurgitation, and mitral stenosis, how to present your findings, and the 4 biggest mistakes to avoid. In this station, examiners assess 3 key skills. Skill A focuses on physical examination technique and routine. Skill B looks at identifying signs and presenting them clearly. Skill G covers patient welfare, including consent, dignity, and comfort. Remember, your primary focus is to examine correctly, find the signs, and present them clearly. The station is typically divided into 4 parts. 2 minutes outside the room to read the instructions and plan your approach. 6 minutes inside the room for the full examination. 2 minutes to present your findings in a structured manner, followed by 3 minutes for examiner questions on diagnosis, severity, investigations, and management. A well-practiced exam should take only 4 to 5 minutes, leaving a time buffer. The examination routine begins with a general approach. Introduce yourself and obtain consent. Position the patient at 45 degrees. Expose the chest fully, maintaining dignity. Practice hand hygiene visibly. Perform a general inspection from the end of the bed. And finally, narrate your inspection findings to the examiner. Step 2 focuses on the hands and face. Look for clubbing and splinter hemorrhages in the hands and assess radial pulse and perform the collapsing pulse test. Check for radiofemoral delay. On the face, look for corneal arcus, conjunctival pallor, jaundice, central cyanosis, molar flush, and examine the dentition and palate. Step 3 involves assessing the jugular venous pressure, or JVP. Position the patient at 45 degrees, head turned slightly left. Look at the right side of the neck. Normal JVP is less than 3 centimeters above the sternal angle. Remember, JVP is non-palpable with 2 components, unlike the carotid. Finally, test the hepatojugular reflux. Never skip the JVP. Always check it and narrate your findings. Step 4 is the precordium examination. Inspect for scars and pacemakers, or ICD bulges. Also, look for a visible apex beat or abnormal pulsations. Palpate the apex beat for its position and character. Check for a parasternal heave and a thrill. Remember, a heave suggests RV hypertrophy or pulmonary hypertension, and a thrill indicates a palpable murmur. Step 5 is auscultation. Listen at the aortic, pulmonary, tricuspid, and mitral areas. Note the location for the respective murmurs and sounds. Finally, perform special maneuvers. Sitting forward with held expiration at the left sternal edge accentuates aortic regurgitation. The left lateral position with the bell at the apex accentuates the mitral stenosis rumble. Step 6 completes the exam. Check for sacral and ankle edema, pressing firmly to check for pitting. Auscultate both lung bases posteriorly for crackles with the diaphragm. Conclude the physical exam by thanking the patient and stating your next steps to the examiners. I would also like to measure the blood pressure and review the ECG and chest X-ray. The winning structure for presenting findings is logical and concise. Start with a summary sentence stating the diagnosis first. Describe peripheral findings, pulse characteristics, and JVP. Detail the precordium, apex beat position and character, and any heave or thrill. Present auscultation findings, heart sounds, and murmur characteristics. Mention completing signs like edema and lung bases. Conclude by confirming the diagnosis and listing next steps, such as checking BP, ECG, CXR, and echo. Case 1 is aortic stenosis, resulting from obstruction and pressure overload. Key signs include a slow rising pulse, heaving apex beat, systolic thrill, and an ejection systolic murmur radiating to the carotids. The classic triad symptoms are angina, syncope, and dyspnea. The presentation sentence should be precise, describing the murmur, location, radiation, and pulse/apex beat characteristics consistent with aortic stenosis. Case 2 is mitral regurgitation, a volume overload condition. Signs include a brisk pulse, displaced hyperdynamic apex beat, and a pansystolic murmur radiating to the axilla. An S3 gallop suggests significant mister. Lung bases may have bibasal crackles. The classic triad symptoms are dyspnea, fatigue, and palpitations. Your presentation should cover the pansystolic murmur, location, radiation, apex beat, and S3. Case 3, aortic regurgitation, is also a volume overload state. Key signs are a collapsing pulse with wide pulse pressure, a displaced thrusting apex, and an early diastolic murmur at the left sternal edge, best heard sitting forward in expiration. The classic triad includes dyspnea, palpitations, and late angina. Your presentation should emphasize the collapsing pulse, wide pulse pressure, displaced apex, and the characteristic early diastolic murmur. Case 4 is mitral stenosis, an obstruction causing diastolic flow issues. Signs include an irregular pulse, malar flush, tapping undisplaced apex, and a peristernal heave. The key is the mid-diastolic rumble at the apex, best heard with the bell in the left lateral position. A loud S1 and opening snap are characteristic. Classic triad symptoms are dyspnea, hemoptysis, and AF or emboli. This quick reference table compares the key features of the 4 main murmurs: aortic stenosis, mitral regurgitation, aortic regurgitation, and mitral stenosis, covering timing, best heard location, radiation, pulse, apex beat, and key extra sounds. The 4 biggest mistakes in the cardiovascular station include skipping the peripheries, leading to misdiagnoses. To fix this, always start with peripheries, moving to the center, hands, face, neck, then precordium. This sequence is non-negotiable. Another mistake is poor presentation structure. Fix this by starting with a summary diagnosis, followed by findings from peripheries, precordium, auscultation, and a conclusion. Chaotic examination order is also problematic. Always follow a fixed routine: general inspection, hands, face, neck, JVP, precordium, and completing signs. Finally, avoid mistake 3, not linking signs to a diagnosis. Always connect each finding with a conclusion. To master performance, practice the routine without a patient until movements are automatic. Time yourself strictly, aiming for 4 minutes comfortably. Present out loud immediately after every exam, leading with the diagnosis. See real murmurs on real patients when possible. Know all 4 cases deeply, and practice with a PACES partner. This helps identify blind spots. Let's bring all together. The 4 common cases are aortic stenosis, ejection systolic, carotid radiation, slow rising pulse, mitral regurgitation, pansystolic, axilla radiation, displaced thrusting apex, aortic regurgitation, early diastolic at left sternal edge, collapsing pulse, mitral stenosis, mid-diastolic rumble at apex in left lateral position, bell only, tapping undisplaced apex. Present with a summary sentence first, then your findings, then your conclusion, with next steps. Avoid the 4 big mistakes. Don't skip the peripheries. Don't present without structure. Don't list signs without linking them to a diagnosis. And don't examine in a random order. This station is winnable. The cases come up again and again. The routine is fixed. The presentation structure is learnable. Put in the practice, and the cardiovascular station becomes one of your most confident performances on the day. Thanks for watching. Inform me about your thoughts in comment section. Stay tuned for next video. Good luck.